Hey everyone, thank you so much for joining us for this tutorial. So today's tutorial is the part 2 on the psychiatry personality disorders, and it's given to us by Tom. So just a few rules. If you're watching via Zoom, any questions or comments that you've got that are covered in the moment, if you just want to pop into the chat, and any questions that can wait to the end, if you just want to pop it into the Q&A. If you're watching on Facebook Live, just comment your questions in your comments and I'll pass them on to Tom. That's all from me, and I'll hand over to Tom now. Thank you.
Excellent. Cheers, Bethany. So tonight is part 2 of what we started on Monday. Basically, we're talking about personality disorders. If you weren't here on Monday, don't worry, I'm going to do a little recap so you can pick up some of the key bits from then, and then we'll forge on into pastures new. Little disclaimer from the Becoming a Doctor people, as always. And then, that's what we did on Monday. So today we're going to think about some particularly challenging and interesting ideas from the world of psychodynamic theory, which are very relevant to personality disorder and very relevant to kind of what you'll see as doctors and what you'll experience. But just going to dip our toe into this quite tricky, confusing, murky area and try and pull out some useful bits from the world of psychodynamics. And then we will talk through other types of personality disorder. So on Monday, we were just focusing on emotionally unstable personality disorder, really, as well as kind of talking more generally about the etiology. And we'll lastly talk a bit about the management of these conditions. So just a quick recap for anyone who wasn't here on Monday, and also, just if you've forgotten what we were doing. So as we said, there's a highly stigmatized group of patients. And that's kind of the biggest reason why it's important to get your head around this topic and try and make sense of it. There's a whole load of other reasons why this group of patients can sometimes, raise challenges for doctors in different settings. But really, I would say the big one is if you don't know a bit about personality disorder, the sort of default setting is quite stigmatizing, and you'll probably, as well informed as you all will be, hopefully by the end of this, you will encounter other healthcare professionals who have quite stigmatizing attitudes to this group. Try not to absorb too much of that if you can, or at least hold on to some of the key messages from today. As we said, this is what we mean by personality, these sort of characteristic patterns of the way you think, the way you feel, the way you behave. And in terms of how it forms, obviously there's a genetic component, but the environmental component is really key. And what's really, really important in terms of developmental environment and the formation of personality is attachment. So we looked at that last time and we talked about the attachment relationship. And this sort of cycle of a baby when they're distressed and being reassured by the mother, and their distress is contained, as it's called. But what this essentially means is the mother thinks about it for the baby, thinks their way out of that distressing situation, because the baby can't think. So gradually, that repeated cycle of like, baby is distressed, doesn't know why, the mother comes in, sorts it out, and kind of names it and thinks about it. You gradually, over the course of your childhood, kind of internalize that ability to think your way out of states of distress. Now, I have a short video to kind of illustrate this a little bit more, which I didn't show you on Monday because we didn't quite have time. But have a little look at this.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
I'm like a girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother.
So just the point that I guess that this first part of the video is making is how sophisticated the level of communication is constantly, even between such a young baby. there's this constant back and forth, and it's within that kind of crucible of communication of sort of intentions and feelings back and forth all day, every day between the mother and the baby. This is how people basically learn how to think gradually. But look at what happens when it's not there.
To not respond to the baby. The baby very quickly picks up on this, and then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, come on, why aren't we doing this? Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it, they actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here.
Okay. I don't know if anyone has any thoughts or comments on that short video. Please do drop them in the chat or shout out on the mics if you want to. But I guess it really shows you, I suppose, how much is going on because of how bad it is when it's suddenly not there. Like, and you see that baby when the mother stops responding to its every intention and thought and feeling, it just falls apart. It's the end of the world for that baby, because essentially it is. Like, if the mother is not responding to the baby and looking after the baby will just die, because babies can't do anything, as we said. So that is the end of the world for that baby if the mum's not responding. And you can see how within 30 seconds of the mum just sitting there with a blank face, the baby completely falls apart, reacts with, good question, would you get away with that experiment ethically now? I think so, because you're just mildly distressing a baby. I don't know. Obviously, you know, you can see the video is a little while old. I mean, it's pretty harrowing to watch, I would say, to see how quickly, like, the baby immediately clocks that something's wrong, and then within seconds, it's just like, cannot cope. So this is really, I guess, an insight into how important attachment is. And we talked a lot on Monday about how important neglect is as a type of disruption of attachment, or as a type of abuse, not just kind of physical neglect, but particularly emotional neglect. You can see how bad that was for just 30 seconds of essentially emotional neglect of a baby. So you can kind of imagine the colossal impact that could have on a person. And that's the kind of thing that leads sometimes to personality disorder. You know that something badly must have gone wrong for someone's personality to have turned out, you know, sufficiently different from normal to cause problems, as we said. Okay, so we also then, I don't know, summarized what we said about, you know, good enough attachment relationships basically allow you to develop normal ways of relating to people, and disrupted attachments and developmental trauma particularly lead to adaptive responses which are intended to ensure your short-term survival. Because ultimately, if you can't get the mother to respond to you, you will just die as a child, as a baby. So you have to do whatever you can to adapt to that situation and get what you need, whether it's becoming impulsive to just grab it and get what you need whenever you have it, or to really scream louder and louder and louder to become incredibly distressed. And remember, we said that it's not just the attachment behaviors that are changed there, it's also the actual feelings of distress, because at that stage in a person's life, they're kind of one and the same. They're two sides of the same coin. You cry because you feel distressed because you cry, like they're the same. You haven't even been able to, you know, I mean, now we think, oh yeah, no, I cry because I feel this way. And it's sort of, there's a cause and effect chain in our minds, which maybe doesn't really reflect the reality. Perhaps they're kind of the same. That's why we call it emotion, as we said. Anyway, so sure, short-term survival, but, you know, in the adult world, this leads to dysfunctional ways of getting along, and a failure to develop more flexible patterns of interaction. And then we talked a little about developmental trauma, how it particularly suppresses the conscious regulation of fear, your ability to think your way out of states of distress, and how this is particularly noticeable in EUPD, emotionally unstable personality disorder, also called borderline personality disorder. It's a bit confusing because BPD sometimes may be used, actually more normally they use BAPD to refer to bipolar affective disorder, which is a very different thing. That's a mood disorder. It's where you have mania and depression. It's not the same. I mean, obviously people can have both, but just a flag up that those two can get confused sometimes. But these are the features of emotionally unstable personality disorder. And hopefully on Monday, we kind of made sense of how all these pop up. So, oh, and then lastly, obviously, we talked through a case. I've got a case or two later on as well to illustrate some other things. But going back to the features of EUPD, we finished just touching on this idea of splitting and projection and what do they mean and what is that? I mean, yeah, to start with, I guess, a little quiz for you. What does anyone know what splitting is or what projection is? This is in a term from obviously psychology, so you might have come across it. Should have put up a poll. That's the way to go. Anyone want to drop on the chat an idea of what those words vaguely mean? And obviously, I will say, like, this is slightly, I wasn't taught this at med school, so I wouldn't expect you to know the answer necessarily. So splitting, categorizing people or objects into black and white, evil and good, X-ray. Exactly, that's exactly right. And projection is, I would say, a bit trickier, so I'll give you the answer to that one. So, as I said, well, I'll just a bit of background. This is psychodynamic theory. It's basically what Freud did. And the key thing to remember that this is all about unconscious to unconscious communication. So this isn't really something that happens in the words that you say to someone. It's much more part of the kind of unseen milieu of communication that happens between people all the time that's not really consciously realized. It's your unconscious talking to their unconscious, you know, non-verbal communication, all that sort of stuff, but it's not even really deliberate. And it's really tricky, therefore, I think, to get your heads around these concepts, because we're not used to this idea that my unconscious has a whole apparatus for reading your unconscious, and neither of us are conscious of that happening. We're not really, and all we do is kind of feel the results of it. So it's a tricky one. It's a bit of a confusing area. So if this all makes no sense and you end up thinking, what? Don't worry about it. But yeah, splitting, as you said, it's the idea of, you know, categorizing people into you're entirely good or entirely bad. And it's not as if certain people in your life are fixed that way. It's more that just, yeah, there's a struggle to hold good and bad in the same person. So I don't know, to give you an example, I saw someone in A&E the other day, had a diagnosis of EUPD, and they said to me, oh, the guy who came and the ambulance man, the paramedic who came and got me from home, he was so wonderful. He was so kind to me. I really felt, I think she actually said, I've never felt so happy in my life. It was quite extreme. When he came and he was looking after me and asking me how I was, I felt so looked after. But these staff in A&E, oh my goodness, they're so cruel. They just want to make me leave. They don't care about me at all. They don't want that. They say that they're looking after me, but they're not. They just want to harm me. So it's really powerful, you know, sense of, oh my goodness, split these two people off into completely separate camps. And basically, I mean, young children kind of do this, like coping with the idea that people can be good and bad is a thing that has to be learned. And it's just with disrupted attachment in early life, it doesn't quite get learned well enough. And it's not the case that people who have EUPD just split everyone all the time. It's just that sometimes, particularly when they're stressed, this can come out and become obvious. And also, it doesn't just apply to other people, it's also yourself. So objects just in psychodynamic theory are anything that isn't you. So other people, that's an object, that's what I mean by that. But yeah, the self. So you might one day feel that you're great, you're doing really well and everything's really positive, and then you make a mistake or something, and suddenly you're completely irredeemably bad and you're worthless and you just deserve to die. Or maybe you are constantly in that place where that's how you feel about yourself. There's nothing good in you at all. And it's someone else, maybe your partner, I don't know, who is just the best thing ever. They can't do anything wrong. Everything is good about them. And we're actually slipping into projection a little bit here, so I'll move on to that. This is the idea that intolerable feelings or aspects of the self are externalized or kind of projected onto other people. So in that example I was saying about, the partner, they're wonderful, they're the best thing ever, they're absolutely great, I don't deserve them, I'm worthless. It's almost like anything good that was in you, because obviously everyone's a mixture of good and bad, is pushed into them, and you only see it in them, and you just have all the badness, and any bad things that happen in your relationship are all your fault and not because of maybe them making mistakes too. So this is kind of what we mean by projection, but it's the really tricky thing where you were talking about this unconscious to unconscious communication, is where you have feelings or things that are projected into other people and they feel them. And that, you hear that and you think, well, are we talking about like mind waves here, that my feelings get put into someone else and they feel them? Like, that's not consistent with our ideas of physics and how the brain works. But this is a thing that definitely happens, and it's an aspect of just someone's unconscious communication to someone else's unconscious. And it's almost like it's kind of a dance between two people. It's not just one person doing it. There kind of has to be aspects of the person who's receiving those that where they sort of fit in and make sense, if you like. It's all quite hard to make sense of without an example, so I will give you an example. This was a patient I saw when I was in my first year of core training, so a year or two ago. She was a patient who was admitted on the psych ward. She had quite a serious suicide attempt, and she had ongoing sort of suicidal intent. And she'd tried to escape twice. So well, anyway, she'd gone out on leave and she'd left and attempted to harm herself. So we were all quite worried, and she was detained under a section of the Mental Health Act for the time being. And also, of relevance to this story, she was a cardiac nurse. So she worked on a cardiology ward, and she wasn't obviously working at the moment, but that was her background. I was called sometime in the middle of the night, and she had a high heart rate, and she was also saying she was having chest pain. So obviously, I mean, I wasn't massively panicked about this. This is the thing that happens, but I was like, right, okay, I need to go and examine her, do an ECG, talk to the medics, see if there's anything worrying going on here, or if, it's nothing to worry about. But she refused the ECG, which put me in a very tricky position, because I need to do the ECG. I can't really call the medics to be like, this person has a bit of chest pain, but that's all I got. I guess you need a bit more to go on. And she was saying, no, I'll have an ECG if you send me to A&E. And then she said, oh yeah, so I've been to A&E lots of times with this, actually. I've gone into supraventricular tachycardia. I don't know how far you are in med school, but this is a fairly serious arrhythmia. Like, it needs treating. It can be quite bad. You can have hemodynamic instability with this that obviously can be fatal. Yeah, I've gone into SVT quite a few times, actually. Yeah, they often give me adenosine, and that's, this is fairly, I don't know, treatment that has to be administered very much in a hospital under close supervision for supraventricular tachycardia. And you can't do this on a psych ward. You need a lot more medical stuff around than is generally available on a psychiatric ward. So now my anxiety is shooting through the roof, because I am feeling, oh my goodness, I need to do something. This woman might be dying for all I know. She has this really high heart rate, and she's saying she's in a bit of chest pain, which kind of suggests that, it's dangerous. But I can't do what I would normally do, just do an ECG, check what it is. If it's SVT, then appropriate management. And also, I can't really just blithely send her to A&E, because I know that she has often tried to leave the ward. And actually, these happened when under exactly the same circumstances, overnight, when you have an out-of-hours doctor who doesn't know the patient well and is inclined to be like, oh my goodness, this is scary, because it's the middle of the night and you're on your own manning the psych ward. And these are when she had run away, when she was going across the car park to the general hospital that's just opposite the mental health unit. And she, throughout all of this, basically appeared extremely calm and chill and kind of matter of fact about it all, even though it was, her who potentially, as far as I knew, had SVT. And I was extremely anxious and panicked, and I was trapped, and I didn't know what was happening, and I just wanted someone to help sort this situation out. And on reflection, looking back at all of this, this can be thought of as, well, projection and also projective identification, which is what you call when the person who's having the feelings projected into really takes them on and acts on them and lives through them. That would be an example of that. Yeah, so a tricky concept to get your head around, but hopefully that maybe makes a little bit of sense. A maybe more straightforward example, which I've seen a few times actually, and probably you will when you're working as doctors. A patient in A&E, maybe who's presented with a small overdose or suicidal ideation or something. They've been assessed by liaison psychiatry, the hospital psychiatry team, and the plan is they can go home. And then they turn around to the A&E nurses, the A&E doctors who are all done from a medical point of view, ready to send them home. If you discharge me, I'll kill myself. Now, I don't know. There's a lot going on there, isn't there? I mean, what are your thoughts? What would be going through your mind if this is what a patient was saying to you, in terms of maybe how you'd interpret what they mean or what you do about it? And this is a tricky one that an A&E medic doesn't quite know what to do with. So I guess I'm pushing you here, but I'm interested to see. Yeah, for sure. Legal implications. They told you they would kill themselves, and you discharge them anyway, if that's what you do. And then then oh boy, whole legal mess. Definitely. And yeah, it's sad, I suppose, that that's the first thing that someone suggested, but also I suppose it is always something that we do need to bear in mind. It's quite important. Not as important as patient safety, but important. Any other kind of thoughts? Munchausen syndrome. Good, interesting point. So Munchausen syndrome, this isn't quite Munchausen syndrome, but I can definitely see where you're coming from. Munchausen syndrome, now called factitious disorder, because Munchausen was a sort of a fictional character that was named after anyway. So it's factitious disorder. This is when you create or deliberately pretend to have medical symptoms in order to achieve being looked after by doctors, not because you want an insurance claim or something like people who pretend to have neck pain after a car crash. It's not that. It's just because you need to be looked after by the medical team. And very much it does absolutely happen in this patient group. The only time you'll really see it is in people who at least have some pretty strong EUPD traits, if not a diagnosis of EUPD. And we talked about that on Monday, I suppose, this dysfunctional ways of seeking help, dysfunctional ways of getting the help and validation that everyone needs, but someone's learned to do that in a dysfunctional way. And very much this is related to that. I suppose this isn't technically, they're not manifesting medical symptoms. That's why it's not factitious disorder, but it's the same kind of thing. I can definitely see what you mean. Do they mean what they say? For sure. Do you know? How do you know if someone means what they say? Well, let's put you all down to the wire. I've just launched the poll. What are you going to do in this situation? And yeah, please do all have a pop at what you do, because this is a really tricky question and many doctors would not know what to do. So I'm just interested to see what your best guesses are, but absolutely no pressure. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay. So we've got a tie here between repeating the psych assessment and assessing capacity, which is great, actually. Like, good shout. None of these answers are really very wrong, to be honest. Probably, actually, I would say, and you wouldn't expect this to be, maybe the most wrong one might be repeating the psych assessment, because unless you have reason to suspect that it wasn't thorough enough. But if the psych team has come and done a full assessment and they've said this is the plan, sorry, but no. To be fair, ask in your situation as an ED registrar, if the patient suddenly turns around to say this, you definitely call the psych team back and ask for what they want to do, and maybe they'd come and quickly speak to the patient. You wouldn't necessarily need to go through the whole assessment again, I guess. Admitting the patient equally is probably not a perfect solution to this, but the reasons for that are tricky. It's a really hard one. I guess, what can you conclude from what this patient is saying? So they've been assessed and the psych team decided this person is safe to go home. I'm happy for them to go home. The best thing for them is to be followed up in the community by the crisis team, who are going to see them tomorrow and keep following them up. And within that plan, there's a containment, like it's kind of essentially like what a mother provides for an infant, but they're like, we're going to respond to you and look after you and hold your distress and make sure you're not on your own with it. So that's all happened. And now they're saying, if you discharge me, I'll kill myself. But the implication is that they want to be admitted. So they have like places, there's some place they want to be, if you like. So it doesn't quite make sense that they're saying they're going to kill themselves, because actually, it doesn't, yeah. It's a confusing situation. They're going to be fine and happy and apparently not want their life to end anymore if they're admitted to a ward. But if they're not allowed to have that particular thing that they want, then they will end them. And so there's a splitting in there for sure. They're like, this is the only thing that is good and will save me. Anything else, any level of support that you can provide in the community, nope, no benefit in it at all. I might as well kill myself. Also, there's projection here, because the A&E medics are going to be like, what do? We can't take, we are the ones responsible for whether this person ends their life. That's essentially what you're feeling, and someone has picked up on this already with the, sorry, I didn't mean to share the results of the poll. Someone has picked up on this already, talking about the legal implications. Like it almost feels like it's on you to make that call whether this person lives or dies, even though they're the ones who are choosing to do that. So it's a tricky one. And I mean, this is a tiny little fragment of detail out of what would be a full assessment where you'd know a lot more about the person. And I'm not saying the right thing to do isn't to admit them, because there are lots and lots of things that are going to go into making that assessment. But so, I mean, if it's someone with really severe depression and they really, really can't cope, and they're, there's ongoing suicidal intent that, is really worrying, you would treat that quite differently, perhaps, to someone who's come in lots of times over the past month to A&E with suicidal ideation, but no attempts, or only small suicidal attempts that you think to yourself, they can't really have been expecting that to end their life. There must be some other motivation for taking that overdose of 3 paracetamol tablets. So there's a difference there between those two in terms of, and you have to gauge, well, you don't have to, the psych assessment team, who are very good at this and do this all day, every day, and this is what I do, have to gauge the risk and work out what is going to be best for this patient. Because actually, always admitting someone when they come in distressed with suicidal ideation isn't necessarily the right thing to do. And it often still happens, particularly, if people are worried and they obviously don't want the risk to be on their head. But equally, if you're kind of constantly, someone falls into crisis, and what you do in response as the psychiatric team is you take them out of their life that is obviously very, very difficult at the moment. You take them out of it completely and you put them in a psych inpatient ward, and kind of there's sort of round the clock care during that time. But then that's only going to last for a short period of time, because ultimately with EUPD, as you know, there's kind of long-standing suicidality. This is a chronic problem, and there will be crisis after crisis, not forever, but certainly maybe for this period of difficult time that this person's going through. This isn't an episode that you can kind of treat in the short term necessarily. You can help manage their distress and contain their distress, but taking them away from their life at home and admitting them and looking after them, and then in 2 weeks' time being like, okay, well, there's, things haven't changed much, and you don't need to be admitted anymore, dumping them back in it is, in a way, it can be a bit re-traumatizing in terms of re-experiencing that caregiver who was there, the mother who was sometimes there and really attentive, and then sometimes wasn't there at all, and all of those dysfunctional attachments that cause all sorts of problems. So it's not a straightforward solution of just like, this person is at risk of ending their life, therefore admit them to hospital. There's more complexities that come in when you're talking about EUPD. I hope this is interesting, but yeah, don't stress too much about it, I guess. You will never be making this decision on your own, absolutely ever, unless you become at least a psych registrar, which I encourage many of you to do, because it's a wonderful, wonderful career. Anyway, so actually probably the right answer in this case would be to assess their capacity and discharge them, because you need to assess that they do have the capacity to make this decision. But if the right plan that is being offered, the best form of support that the psych team in all their experience has judged, the best way we can help this person is not to admit them, it's to support them in the community to carry on and get through this crisis and that sort of thing, that's going to be the best thing. If they're kind of making these threats essentially to harm themselves, you have to assess their capacity. Are they of sound enough mind to make that choice? And then you have to discharge them. And it's a really hard thing to do. So yeah, don't worry that you're balking at that idea. But clearly you will always talk to seniors who will speak to the psych team and you'll work out the best thing to do. But yeah, this is a kind of a good example of how these patients can cause such panic and problems. I say, no, that's a pejorative way of putting it. How their dysfunctional patterns of coping with distress that they never had the opportunity to unlearn since childhood, how those dysfunctional patterns that the patient has no control over themselves really, or at least not until they've had some fairly extensive psych input, they have no control over that those patterns are causing the problem. But obviously the way you, on face value, the way you make sense of it is this patient is causing me jip by saying this stuff and making these threats. That's how you might tend to approach that. But hopefully, if you see this in the future, you can bear in mind some of the other stuff that we've talked about. Question from the chat. So what you're saying is if they have capacity, the best thing is to discharge in the community, discharge and treat in the community. I'm saying sometimes the best thing is to do that. And it very much depends on the whole case. And it's absolutely, that is not necessarily the right thing to do for everyone, of course. But I'm guess the context for this particular one, and I understand that this whole idea is a bit mind-blowing and confusing. I didn't mean to open too big a can of worms, but if the psych team has assessed them, perhaps they know them well, this patient, and that's the kind of situation this would happen. Usually if someone's presenting for the first time and they're saying they're going to, you would admit them and you'd make sure you really get to the bottom of what's going on. But the only times where the psych team would be advising this is as someone who perhaps is known quite well to services. It's known that they have a diagnosis of EUPD. This is a repeated pattern of coming in. Maybe they've had a whole bunch of admissions over the last few years, and it hasn't helped. The admissions don't help. They kind of make things worse. And so you're seeing this latest reiteration of this pattern. And for all of that context and that reason, the psych team, probably in discussion with the consultant, because it's a risky thing to decide, is saying, no, the best thing in this case is for this person to go home and be supported in the community by the crisis team, because admitting them again is not going to be helpful. But yeah, sorry, don't go away thinking, oh, these horrible psychiatrists just send people home even though they're in so much distress that they want to harm themselves. It's not quite what I mean. There will be a lot of context behind that call. So I'm glad you asked that, so I could just clear that up. Okay. On we go. That's what we did already. Fine. So, other types of personality disorder. I'm going to focus on one in particular, which is antisocial or dissocial personality disorder. And some of you may have kind of heard of this, encountered it a little bit. It's the other one that you might come into contact a bit maybe in a healthcare setting, or at least it's quite an interesting one and it's a challenging one to make sense of, and it's very much a stigmatized one. So I want to focus on it particularly for a few minutes, and I'll probably whiz through the others because it's not so important to know a great deal about them. But dissocial or antisocial personality disorder. This is what is kind of colloquially, I guess, known as a psychopath. I mean, technically in the field of psychiatry, a psychopathy is something quite specific within this diagnostic group. But basically, when a layperson talks about a psychopath or a sociopath, they're referring to this diagnostic construct. And the features of it are, as you probably know, this kind of lack of empathy, disregard for the morality of society, kind of lack of remorse for wrongdoing, as well as tending towards using violence or becoming angry kind of as a go-to means of coping with distress. So they'll become distressed and they'll become angry, violent. And also a feature of it is sort of impulsivity, very much like EUPD. Impulsivity is a key trait of that. And this kind of thrill seeking as well, you sometimes see kind of a need to be stimulated. So drug use is huge in this group, as you can kind of imagine through the combination of those two things. And I think it raises a really interesting question, kind of almost on a philosophical level. Not that I'm going to go too far down a philosophical rabbit hole, but this personality disorder comes about similar way to EUPD that we've talked about already. It's more common in men, and a classical case would be a boy who, for whatever reason, has gone into care at a very young age, been brought up in the care sector, fostered time and time again, never really had consistent, secure attachment figures looking after them, maybe never had sort of secure boundaries, all this sort of thing, and maybe has experienced abuse. Perhaps that's why they were taken into care in the first place. But neglect is particularly damaging for boys. So that will be the background, and that is what tends to cause this type of personality disorder. It doesn't just happen for no reason, generally speaking. Obviously, there is a little bit of a genetic component, but that aside. So you see someone with fully blown antisocial personality disorder, then you look at their case notes and they grew up in the care system, they were abused, they had a horrible life, and you're like, okay, I can understand that. That kind of I can see why this person has turned out like this. But then think of someone that you know, anyone who is a bit selfish and is a bit, they definitely don't have antisocial personality disorder for sure. And you wouldn't really describe them as a sociopath, but they just don't really care as much about other people as average people would. And maybe, I don't know, if all your friends are medics, perhaps that's not an ideal, because I guess often people go into medicine because they really, really do care about people. But yeah, you probably may know people who just you think are a bit selfish and don't really care about other people, maybe are a bit impulsive, whatever. But that's not an illness, is it? That's just not being a very nice person. But ultimately, what is the difference between antisocial personality disorder and just being a dick? Like, what is the dividing line between those two things? And the cold truth is that there isn't one, really. It's just depending on the environment that the person has grown up in, how bad it was, and and whatever mix of genetic things. But there's just a continuum between someone who is perfectly saintly and cares more about everyone else than themselves, all the way to someone who is full on a psychopath and commits crimes and has no empathy. And somewhere in the middle, there's you or I. Somewhere in the middle, there's someone who's a little bit selfish. And we've all just developed in the environments that we developed in and developed the personality traits that were the best response to that environment, essentially. And it's not to say that, anyone who's a bit selfish, they might have been a little bit abused in childhood. It's not going to be something as big as that, probably. It's just going to be a bit more low key. But there is ultimately no real cutoff line between these two things. And that's a tricky thing to get your head around, I think. And it's a problem for the whole of the field of personality disorder. It's one of the problems with it. There are no firm cutoff lines. You'll see lots of people who very definitely fall cleanly into the ballpark of having EUPD. They have all the features, and you can make that diagnosis quite comfortably, or sort of uncomfortably. But, it's not always as straightforward as that, which I'll touch on in the next slide when we talk about other types of personality disorder. There is a whole menagerie, which I wouldn't worry too much about it, to be honest. But yeah, we've talked about emotionally unstable personality disorder. We've also talked about antisocial or dissocial personality disorder. Then there's a whole bunch of them, which I'm gonna whiz through in very brief, and you can have the slides and refer back to them later if you want to. But basically, none of them are really particularly common. Also, the categories are being a bit reworked next time they release the International Classification of Diseases. And also, they're not separate boxes, and that's a really key thing to understand. Don't worry about that. I don't know, I got this diagram from some random paper. The point I'm trying to convey, I guess, is that people exist somewhere on the spectrum. So usually, someone might have emotionally unstable personality disorder, but they also have some avoidant and dependent traits, or they have antisocial personality disorder with narcissistic and paranoid traits, whatever. That tends to be how it works. So I'm going to whiz through what all these words mean. But I just want to put a warning label on this. I guess by their very nature, the way we describe these sounds bad. Like we're describing personality traits that cause problems. Therefore, we're basically describing personality traits that society doesn't like. And you can ask lots of questions there about, is this right to call this an illness, or have you just labeled something that you don't like? And it's fair to ask that question. I guess when you are talking about diagnosing someone with a personality disorder, it's really quite severe. And generally at that point, you can see the reasons for it in that person's early life. But yeah, the descriptions of it are often highly pejorative. Also, there's the idea that you put people in separate boxes, which, as I've said, isn't really true. Some of the ideas, particularly things like histrionic personality disorder, I don't know, a bit sound outdated. It's quite old-fashioned psychiatry, so I take it with a pinch of salt, perhaps. And also, like, you'll see some of these traits in lots of people to a small degree, and that's kind of normal. So without further ado, narcissistic personality disorder. Basically what it says on the tin. I don't know if I really need to talk much about what this word means. This is kind of what it is. This basically intense self-belief to the point that it causes problems, and really you're kind of degrading everyone else around you because you believe you're better than everyone else. Again, you'll see a lot of this in your life, and just normal people who don't really have a diagnosable personality disorder but have some of those traits, and to an extent maybe they're useful in some situations. Anyway, and I guess you can think of this in terms of its etiology perhaps as a defense about experiences in childhood of being completely powerless and worthless, and almost the way to defend against that horrible period of experience is that you kind of jump to the opposite end of the pole, and the only way to keep those feelings out is to be the opposite and to be I am the best thing ever, perhaps, is a very simplistic way of putting it. Anyway, that's narcissistic. Then we've got histrionic, where it's, yeah, and this there's some relationship here with a bit of the sort of the Munchausen syndrome that we were talking about in terms of, you know, doing stuff for attention, which is again a very pejorative way to put it. But you've got to understand that as a means of getting help from other people. But yeah, equally, you can see this is bleeding a little bit into narcissistic personality disorder, and that you're seeing perhaps some of the overlap between all the different categories, and that it's not really that helpful to think of them as separate boxes. Yeah, that's histrionic. And then we have anxious avoidant. Oh, sorry, my slide's a bit doofus. Yeah, and this is, so I think, and so I did the talk on anxiety disorders a little while ago for you guys. I don't know if anyone who is here tonight attended that, but we talked about trait anxiety as this sort of basically multifactorial stable personality trait, how likely you are to experience anxiety, the feeling of anxiety, I mean, under a given set of circumstances. And it's perfectly normal to have, you know, fairly high trait anxiety where you get really, really stressed about exams at the beginning of first year, or really low trait anxiety where you're like, oh shit, the exam's in 2 weeks, I should probably start revising. But I suppose the really severe end of really, really high trait anxiety would start to look like anxious or avoidant personality disorder. Yeah, so that's kind of what that is. Then dependent personality disorder, yeah, is often comes along perhaps with EUPD sometimes, and it's again kind of what it says on the tin, like, and there's a sense of, you can see maybe echoes of what we talked about in terms of splitting and projection, that like, I am completely useless, I can't do anything, I need this other person, perhaps a partner or a mother or whoever, or maybe various different people, I need them to sort out my problems, I can't possibly sort them out myself, that sort of thing. So that's dependent personality disorder. Paranoid is a tricky one. I guess if you were to guess what paranoid personality disorder is, you might think it's to do with paranoid schizophrenia, and you have funny beliefs that people are out to harm you. And it's not quite that. So paranoid really means stuff revolving around the self, like Noia is sort of the self, and para is, I don't know, I don't know, I'm not a Greek scholar, but essentially this is someone who is, you know, very inclined to bear grudges and to think that other people are trying to wind them up, you know, misconstruing neutral actions. I saw a guy who had paranoid personality disorder who was admitted he also actually had an episode of psychosis, but underlying that he had paranoid personality disorder. And he told me, and this wasn't really a feature of his illness actually, but he was telling me about how his neighbors would always like put their bins slightly too like in front of his front garden instead of theirs, and who was got so angry about it and was like, this is like, they're trying to wind me up, they know that I don't like it and they're doing it deliberately to make me angry and I hate them and all this sort of stuff. So that, yeah, I guess you can see that. That's what paranoid personality disorder essentially is. And again, it relates a bit to narcissistic personality disorder perhaps. And then schizoid is a bit confusing. I've only ever seen this once in my life, it's quite rare, but it's schizoid. Schizophrenia means split mind, and it refers to splitting off of the different functions of the mind. So you think a sound, but it actually sounds like it's coming from outside, that sort of thing. That's what schizophrenia means. And the schiz bit means splitting. So schizoid personality disorder is essentially you're kind of split off from the rest of the world and you just don't really feel it. The guy I saw, he kind of said, yeah, he described all of these things that he likes to be alone. He doesn't really care about anything in his life. He goes through the motions of daily life and studying, but actually he said to me, I think I'll probably kill myself, I guess, maybe in the next 10 years, because I just I'm not really bothered to go through the endless boring motions of life. That's kind of split off from anything that might be fun or enjoyable. So that's schizoid personality, yeah, pretty rare. And then schizotypal is actually classed under schizophrenia-like disorders in ICD-10, but it's basically you're chronically kind of, I suppose, have some features of schizophrenia and at a sort of low level. So this sort of odd beliefs, magical thinking, definitely would be into a whole lot of conspiracy theories, for instance. Again, sort of paranoia might be a feature of it. And sometimes you'll have low-key psychotic experiences or psychotic episodes. And I mean, people who have schizotypal personality disorder are very likely to have fully blown psychotic episodes and schizophrenia as well on top of that. But I guess the personality disorders, they're always a bit like that. So there we go. Oh, and lastly, this is the one that's probably most relatable, I think, for all of us med students. Anankastic, or obsessive compulsive personality disorder. And this is what you mean probably when you say, oh, I'm so OCD about such and such. Because that's not what OCD is. As I hope you're maybe aware, OCD is an illness where you experience lots of intrusive thoughts and it's really, really distressing. And then you have to do things to make those thoughts go away, such as classically washing your hands to reassure yourself that you don't have dirt on your hands that's going to kill you. That's what OCD is. But obsessive compulsive personality disorder is quite different. I mean, there is an overlap with people who have this also then getting OCD, but it's the like obsessive, everything has to be done my way. I'm very fastidious, very, very, perfectionism to the point of it being a real problem in that person's life. So yeah, but I think this is a good time to think about how actually these, for sure, some people have traits to an extreme that is a real problem for them. You can imagine how if this is really, really, really extreme, it'd be hard to get on with this person, and it might cause problems in their life. But actually, I do want my anaesthetist to have a little bit of obsessive compulsive personality disorder when I go in for my leg operation, whatever. I want the pilot flying my plane on my holiday to have a little bit of obsessive compulsive personality disorder, because in certain roles in life, you need people who are going to absolutely want things to be done the correct way and are very fastidious. And that's, I guess, a way of saying that all of these traits that we talked about, and I mean particularly these ones, to be fair, are useful in life. It's only a problem when they become to an extreme. But everyone is sort of on the spectrum a little bit. Obsessive compulsive personality disorder is actually the most common personality disorder, and I guess you can see how those traits are kind of the most useful maybe of all the ones that we've talked about. There we go. Those are all the types of personality disorder. They can also be subdivided into types A, B, and C, which I haven't done because that's kind of gone out the window a little bit and isn't used much anymore. But you may need to know that for exams, so you can look at that. But it's just in the order that I've presented them. The first few were A, the second few were B, then they were C. There we go. Management of personality disorders. And also, please do drop any questions on the chat if any of that was confusing or it makes you angry or you don't agree with it. Please hit me. I don't know why that's there. Right, how do you manage these? Because there's a perception perhaps that these are untreatable, that, and I guess I've maybe given you that sense that like this is something that is laid down in your early development and it's how your brain forms and then you're stuck like it for the rest of your life. But that isn't really true. Taking EUPD as an example, because that's what you'll see a lot. Sometimes people can, maybe they've experienced trauma in early life or disrupted attachment. So under the surface, there may be some EBD traits there, but they might still be able to function perfectly normal in life. And actually those traits don't really come to the surface. But perhaps then, and I'm just thinking of a particular patient I saw, maybe they're bereaved or they are abused or they're assaulted by someone as an adult, maybe even age 40, 50, something like that, that they experience another trauma that really, obviously would knock them right back to how they felt when they were traumatized as a child. And suddenly the traits can come out and cause much more of a problem and be much more obvious. So someone and then they can go away again after time, potentially. So someone doesn't necessarily meet the diagnostic criteria for a personality disorder their whole life through. The traits are quite stable over time, but they might not necessarily cause a problem all the time. So don't think of these as fixed completely. And also they can be treated. And the mainstay of treatment, as you might guess, is psychological therapies. It's all about psychological therapies. So we talked about EUPD and about the problems that occur with disrupted attachment, about how you're kind of unable to think your way out of distress. You're almost not even able to make sense of it. You just feel it and you act on it, and that's all there is. You're like that baby that's crying and it doesn't know why it's sad. It's just sad. So that's, I guess, what the baby eventually learns with appropriate attachment is mentalization, the ability to think about thinking, the ability to feel those feelings, but also almost step back from them, be like, this is what I'm feeling distressed, okay, and this is why I'm feeling distressed, and then think your way out of it. That's what mentalization is, and there's, this is basically a therapy that enables people to develop it, to really try and work through the ability to learn that skill, essentially. And it can be learned. It's just that it wasn't learned in early life, but it can be learned. Dialectical behavioral therapy, you may have heard of, DBT. It's the gold standard for EUPD treatment. And basically it's similar to, it involves elements of mentalization, but it's all about learning better ways to cope with distress. Because that's just, anyone with EUPD, the core deficit, or one of the main core deficits, is they haven't learned good, effective, functional, non-destructive ways to cope with the extreme distress that they will often experience because of everything we've talked about. But you can learn better ways to manage and think your way out of that distress. And it often involves, there are elements of mindfulness, and there's lots of, various things involved in DBT to help someone basically stop self-harming is the classic one, because that's often what people use to manage distress when they have a UPD. And then psychoanalytic psychotherapy is super interesting, and you could spend a whole hour, you could spend a whole day, you could spend a week just talking about what it is and how it works. And I don't think I can really start because we've only got a few minutes left. But this is sort of the Freudian psychotherapy that you imagine when you think about psychotherapy. Most psychotherapy is not like this, but the kind of sit on a couch and just free associate, say whatever comes into your mind, you probably end up talking about your mother, this sort of thing. That's what psychoanalytic psychotherapy sort of is. But it's fascinating. I'm happy to talk a lot more about it at the end if anyone's interested. But I'll leave that for there. But basically, this again is a way of helping to relearn some things that weren't learned well enough in early life. And then you do use meds. You can't make a personality disorder go away. You can't treat these ingrained patterns of thinking with a medication. But people with personality disorder, because it's a difficult way to live, they will often develop depression, anxiety, psychosis, perhaps all sorts of things. And it's appropriate to treat those with medications. But yeah, so they have a specific limited role, to coin a phrase. Yeah, and then therapeutic communities are amazing. Again, I would love to spend ages talking about them. There's one in Richmond called the Castle Hospital. If you ever get the opportunity to visit a therapeutic community, they're incredible places. It's sort of like residential psychotherapy, but the mainstay of the therapy is living together with 15 other people who also have usually EUPD, because that's kind of the most common personality disorder in healthcare settings. So you're kind of living, and yeah, loads and loads of stuff happens there in terms of how the treatment works. But part of it is managing your collective distress together. But, if one person on one particular day is so distressed that they just want to scream and storm out of the room, other people will be having a good day and they can offer advice and help to contain that distress. And it's kind of better perhaps than coming from some healthcare professional who actually I don't know what it's like to have a UPD and feel that distressed. It's not within the range of my experience to have felt that awful, but someone else may well be able to relate more powerfully. So there's a really powerful thing in terms of that peer support, and also lots of other stuff that happens in a therapeutic community. It's really fun. Tragically, particularly for antisocial personality disorder, it's very often managed in a forensic setting, often, in prisons, like 50, 60, some studies say 80% of people in prison have a personality disorder, generally antisocial personality disorder. So that's often where these people will end up, very sadly. But I mean, yeah, all sorts of discussions about whether that's the right thing to do, because, you know, so just because someone has a personality disorder doesn't mean you can consider them not responsible for their actions. And actually, maybe the most often the best way to try and enable them gradually to learn that is to, you know, respond as you should respond to someone committing a crime, that sort of thing. It's a tricky question. Anyway, there's a question on the chat, or a couple, in fact. So, would it be a good idea to give someone with dependent personality disorder medication to help them cope? What if this creates an unhealthy reliance on them? So I suppose dependent personality disorder is generally about dependence on a few other people, typically on like a small number of other people, but sometimes lots of other people. It's not so much related to kind of drug dependence. Kind of anyone can become dependent on substances. And that's not, I suppose, what dependent personality disorder really is. In anyone who experiences chronic distress that maybe isn't really part of like an acute episode of anxiety, whatever, then you have to think about what the roles the medication is going to have, because if the chronic distress is to do with EUPD and it's going to be there maybe for a long time, or it's to do with anxious avoidant personality disorder, whatever, then you have to be realistic about what the medications can achieve, and maybe there are better treatments. However, you know, it's not inappropriate to use medications. I would say, I guess, I don't know what stage you're at and what you know about psychiatric medications, but for instance, antidepressants like aren't addictive in any way. They don't give you any kind of buzz. They take a number of weeks to start working. So there isn't an issue really with becoming dependent on them in terms of becoming addicted. And ultimately, like, I don't know, personality disorder completely aside, if someone has recurrent episodes of depression and they stay well on sertraline, then maybe it's the best thing for them to continue that sertraline indefinitely. And you can say, oh, they're dependent on a medication, but I don't know, someone with diabetes is dependent on insulin. Like, so what? They have an illness and we're treating it appropriately, and we're doing what's best for them to keep them safe and happy and live their best life. So hopefully I've answered that question in a waffly way. This is all new to me. How good. Where does CBT as management come in, or are these forms far more advanced? So CBT is a brilliant therapy that's used for basically for depression and anxiety by and large. Also use elements of CBT for eating disorders, use it for OCD, all sorts of these kind of common mental disorders. And they basically involve thinking about the patterns of thought that are driving your depression or anxiety. So like, I could talk a lot about CBT. I don't want to turn this into a CBT teaching session, but basically you can use CBT to help manage someone's depression or anxiety, even if they also have personality disorder underlying that. That's fine and good. But sometimes it might be difficult to maybe engage with CBT because it involves a lot of, it's cognitive behavioral therapy. You're really trying to think about what goes on when you're distressed. And actually that can be quite hard for someone with EUPD, for instance, for all the reasons we've talked about. So maybe mentalization-based therapy might be better. It's not so much that these are more advanced as such, really. They're just different and treat slightly different problems. And often people will use a kind of mixture of different therapeutic techniques with someone. And then ink blot tests, are they still used in psychoanalysis? Yeah, no, they're not really any used anymore. They're a bit irrelevant now. I mean, I'm not saying no one ever uses them. Maybe in the States where they do all sorts of wacky things, potentially. But no, the Rorschach test, as it's called, I've never seen it used. But anyway, right. So the takeaway messages, and this isn't the last slide, there are a couple more things. As we've said, so I'm just moving all my boxes out of the way. So hope we've got a sense of how difficult this topic is, and don't worry if it's all still confusing and feels all wrong and you don't think this diagnosis should exist. I kind of agree with you. Firstly, whenever I'm counseling someone on a diagnosis of personality disorder, I almost open with an apology that we don't have a better name for this group of disorders, because it's just a horrible thing to be told, isn't it? Your personality is disordered. Hopefully you've all now got a bit more of a sense of what that means, and we'll have a slightly kinder view of that idea, but still, yeah, it's not an ideal label. So that's only starting with the name of it. There's all sorts of problems. But the best way to approach it is adaptations to developmental trauma, to attachment that hasn't gone quite right. And every brain just does the best it can in its situation to survive. And it causes these inflexible patterns of relating to others and also to yourself. And particularly they tend to emerge under stress. And they can do that in anyone. Anyone can become a bit anankastic or a bit dependent or a bit avoidant, whatever, when they're under stress. That's very, very common. I guess the maybe defining feature of a personality disorder, it really happens a lot of the time and they don't have other ways of coping with stress, or you find it difficult to use the whole plethora of other means of coping with stress that most of us have. And it's really important to maintain compassion for these patients, treat them like a human being, even if things about the way they're presenting to you make you grumpy or annoyed or frustrated. There's one thing that I want you to remember. So if you can hit the chat, think back to when you were, I don't know, 5 years old. What did you want to be when you grew up? So I'm gonna, if no one volunteers, I'll just pick on people. Aaron, what did you want to be when you grew up? Ah, God. Okay. Well, Andrea then. I'm picking on the people who are first in the alphabet. Anyone? Surely you must have. I don't know. I don't mind what it is. I don't know. Maybe you all wanted to be doctors and now you're living your dream. Oh, great. Marek wanted to be a doctor. Absolutely smashed it. Well, I think I wanted to be a dragon. Oh, good. Someone else wanted to be something ridiculous as well. Wanted to be a monkey. Cool. Yeah, you all wanted to be some great, cool stuff. Let me tell you now. Ask 100 5-year-olds, ask 1,000 5-year-olds, ask every 5-year-old in the world, and none of them will say they wanted to be this person. In and out of A&E the whole time, 3 times a week with another overdose, in and out of psych hospital with problems that aren't getting better, flying into crises whenever something bad happens in their life. Like, nobody wants to end up like that. And no matter how a patient presents to you, how frustrating, how difficult, whatever problems they are causing for you, remember that they didn't want to be like that. Once upon a time, they were a little kid that wanted to be a doctor or an astronaut or a dragon. And they are just a person, and their brain has automatically adapted to the environment they grew up in. There was no choice involved, and this is just kind of what's happened. But I could just urge you, as the only thing that you take away from this whole teaching session, is just to remember that. So that's the end. Please do fill in the feedback to feed my ever-hungry portfolio, and I'll be exceedingly grateful. And I will answer a couple more questions that are on the Q&A panel. Oh, Aaron did answer the question. You wanted to be a police officer. Sorry, Aaron, I didn't see that. And yes, I wanted to be a dragon. Fine. Okay, there weren't any questions. But I don't know. Any other things you want to know about this nightmarishly confusing topic? Please drop me a question, or I'll put my email again in the chat. So feel free to drop me an email with any other questions that you might have. Oh, there's another question on the Q&A. How successful are the therapies? Great question. So it's quite difficult to completely change someone's personality, for sure. There's a degree to which you're not going to be able to completely shift those traits that are laid down when someone's very young. So in terms of completely curing someone of a personality disorder, I guess they're not always super successful, just because that's a really hard thing to do. But they are very, very successful in helping people have a much better quality of life. It's funny you should ask that question today. So I've been seeing a patient for a year, just coming to the end of the therapy for psychoanalytic psychotherapy. And they just are able to think more now about all of the things that kind of recurrently seem to go wrong in their life. I wouldn't say that they're a different person, but there's a clarity in the way that they understand where they're at, and they're not arguing the whole time with their family now, because they can kind of see have a bit more insight into what goes on there. They still argue a bit, so the problems are still there, but there is a real change, and it's really, really encouraging to see. So it takes a long time to shift some of these traits sometimes. So it's not easy, but for sure. And I haven't given you any actual numbers about how effective the therapy is because I don't have them off the top of my head. How much insight do people have in terms of having a personality disorder? So great question. Yeah, that's a common feature, is a lack of insight. That is very often a characteristic feature, particularly if someone hasn't really had any treatment, hasn't been given a diagnosis, whatever. Everyone else is the problem. They won't have any insight into their own patterns of thought and behavior. But people can gain insight, and people can, accept their diagnosis of EUPD and see that actually, stuff happened in their life that's caused them to develop these particular patterns, but now they're more aware of them. They're able to not fall into those same patterns again and again and again. So insight is possible. And what kind of percentage of people with personality disorders make up Mental Health Act admissions? Good question. So I don't know the percentage, but there are definitely a few. Most admissions under the Mental Health Act, I would say, are with psychosis. Psychosis, schizophrenia, that's kind of the most common thing. And if you see someone who's relapsed with psychosis, you're quite likely to be considering admitting them under the Mental Health Act. Particularly, insight is often poor, and they may not want to be treated, but with a little bit of help and a short time of being treated against their will, they can get back to normal and be like, oh, well, thank goodness I was admitted and I got that treatment, now I'm back to normal. Anyway, but yeah, people with personality disorders are fairly often admitted because it's not always as, I hope I didn't trouble you all too much with the example I gave earlier, I guess, but sometimes, you have personality disorder, but someone also has a really bad depressive episode at the same time, and admission is appropriate. So yeah, but I don't know the actual numbers. Right. Lovely. I hope you all enjoyed that. Thank you very much for your feedback. And I guess I will see you next time, whenever that may be.